for everybody coming out tonight. Dr. Stewart Long. I was asked to talk about the advances in heart surgery. And basically the major revolution has been regarding the aortic valve. Lately, this valve right here, kind of not totally in the center of the heart, but kind of right at the top of the heart. And so the normal valve opens up and closes. It's a pretty simple function. The major problem that we see most commonly is the valve is too tight, called aortic stenosis. It can also be leaking, but generally this is the most common one that's really been the most progress has been made as far as advances go. It's a pretty serious problem, and I like to tell patients it's essentially a fatal problem. Once patients get symptoms, about half of them are dead in about 2 or 3 years. So that's kind of the background drop on what you compare all the other therapies to. Basic indications are when the valve gradient gets pretty high, over 40, or the heart function starts dropping. Essentially a tight valve with symptoms, or if we're going to go do other surgeries, we'll address this valve at the same time. Historically, we've kind of had surgery as the main choice, conventional open heart surgery where we put in valves and kind of have the mechanical valve, or basically there's a pig root. These are cow valves. Basically tissue valves versus the mechanical valves. And this all got kind of pioneered 1970s and 80s. Things kind of got worked out. And surgery has, the other major advance in surgery is routine surgical valve replacement has gotten safer and safer. Here's the major revolution, a major advance. It really came about for patients who were too sick for that traditional open heart surgery. And it has gradually come down to now becoming the foremost therapy and probably will become the default therapy for this problem. This is called a transcatheter aortic valve replacement. So no longer is the chest opened, but the majority of patients get the valve replaced right through the groin. Here's a competing company called Medtronic. This is their valve design. A little bit more of a cage, and the valve sits a little bit higher up. So the one before that was Edwards. This one just goes right inside the where the old valve was, and it expands on a balloon. The new this other one just kind of self-expands. Pretty amazing technology. As far as surgical advances, basically the incisions have gotten smaller, and we've basically had safer outcomes. Conventionally, full sternotomy, this is appropriate still for many patients. You can approach the heart valve through a small incision in the side, or most commonly here at the Heart Institute, we kind of divide the upper part of the breastbone. Here's our most common incision surgically, and say this is one of the more advances on the surgical aspect of things. This is kind of what it looks like. Small incision, 6 to 8 centimeter range, depending on the patient. Directly down, open up the aorta. We cut the valve out and basically sew a new valve in conventionally. So if you can see this technique, the sutures are put around the hole. Sutures go through the valve, and the valve drops down. And then we sew the tube up the aorta. And there's your open heart or surgical valve replacement. And that's what we call the minimally invasive valve replacement. This is well tolerated, a little bit gentler, particularly if people have bad lungs. The major difference is less blood loss compared to the open surgery. Here's the revolution, is the transcatheter valve. There are different ways to get it in, but essentially the valve is on a catheter, the balloon blows up, pushes the old valve out of the way, and leaves a new valve in place. This diagram shows it coming up from the leg, which is coming around the aorta into the heart. Right now, this is 95% of the patients are candidates for this approach. If for some reason the blood vessels aren't big enough in the leg, there are other approaches. When the valves first came out, we had to go through the tip of the heart more, but the technology has advanced, and these catheters are smaller now, so we can go up through the leg. When it first came out, half the people had through the tip of the heart, half were through the leg. The patients who can get to the leg basically did better. Long run, so the technology just kept pushing for smaller valves, or smaller devices for the valve. So we've done over 500 at the International Heart Institute, and we've been doing it for about 5 years. When we first started, I thought we may do 20 a year, and it was only limited to the very high-risk patients. Last year we did 160, and this year we're on pace to maybe even do over 200. It's incredible, the demand and patients are coming from all around the state. So when we see patients with the primary problem with aortic stenosis, we talk about valve choices. Tonight I talked to a young gentleman who was 29 years old, and he's going to be an excellent candidate for the standard mechanical valve. It's basically he will live longer versus the tissue valves. When people are over 70, the tissue valves become the predominant choice. There's no real difference in survival. The real debate is when you're between 50 and 70, and basically you have to choose between being on a blood thinner, which has some annual risk of bleeding or stroke complications, versus a tissue valve like a PIG valve that will likely wear out and need some sort of replacement, whether it's a surgical replacement or a TAVR valve put back in it. So there's some questions about putting the valve inside a valve. We do it quite often. It all depends on how big the valve was to start with, how the ultimate result is. So there have been some associations. When you put a valve inside another valve, is it correctly positioned? Did the valve gradient get high so you still have a little bit of obstruction? And this is, again, compared to the mechanical valves, bleeding and stroke events. So again, the transcatheter indications have gradually gone down. When we first started doing this 5 years ago, only high-risk patients for their perceived death rate from open heart surgery was 8%. Then just a couple of years ago, studies came out that the valve was equivalent or even superior as far as death and stroke for the intermediate risk patients. And now we just came out with a low-risk trials, which I'll go over again, which also showed at pretty early time frames either superiority in some aspects or non-inferiority. The big issue now is we don't know exactly how long these valves will last. We have 5-year data. That's so far so good at 5 years, but that's the big question mark. And the other issue is there are more pacemakers with the catheter valve. When you blow the balloon up, the valve's pushing the old valve into the conduction system. Compared to surgery, the surgical pacemaker rate's roughly 3 to 5%. In the papers, the pacemaker rate, one company, the Edwards, around 10 or 12%. And the latest one on the Medtronic valve is up to almost 20%. So that's an issue. When the valves first came out, they had issues with leakage around the valves. And again, the advances over the last 5 years have taken that leak rate from 15 to 20% down to now around 2 or 3%. And very, very low issue at this point in time. Compared to surgery, there's a lot less bleeding, less kidney failure, less irregular heartbeat after surgery. So pretty dramatic. Initially, the stroke rates were similar, being better in high risk, but actually the latest low risk trials even showed lower stroke rates for the transcatheter valves. So who are we going to do surgery on? We'll probably still do it on the young patients like I talked about. The one patient population that has not been included in the studies are bicuspid valves, where the valve has 2 leaflets instead of 3. So that'll be a debate. This valve's more likely to get some leaks around it, the TAVR valve not quite fit as well, although we have treated this valve successfully many times. Or if you need something else done, you need a bypass done as well. Currently, if the valve's leaking, it's not a platform to put in, you need something to anchor the valve. Or if you have an associated aneurysm, part of the aorta coming out of the heart's big that needs replacing. Well, those are other reasons to get open heart surgery conventionally or minimally invasively. Or AFib, if we can go in and do a procedure to treat the AFib at the same time, is also a good reason to cross over and consider having the open heart surgery. So one thing we do have, and I think in my bio, I do like the heart team. I think that's probably one of the advances that has come with TAVR, is now we really function much more so as a team with our cardiologists. We almost see them too much. We talk every Monday mornings, Tuesday mornings in the hall, constantly debating back and forth what's the best therapy for the patient. So they understand our world now as surgery, as some of the early times we had to actually do surgery in the cath lab to convert for complications of the TAVR. That's gotten very low now, less than 1%. And then we understand their world, their catheter and wires and the limitations of all such. So we're kind of debate now which is the best treatment. TAVR is becoming the predominant therapy for patients who are selecting a tissue valve. But there are a lot of other things that are coming into play, the need for future interventions, if they need future stents. And you can see those two different valve choices. One was short, one was big, and that getting through that bigger cages could have some difficulties putting stents in future patients. And the other thing that is favoring TAVR are ladies with small valve sizes or annuluses, so the size of the valve you can put in. Patients with small annulus are more likely to get what we call patient-prosthesis mismatch, where the valve is relatively small for the patient. Some of the intermediate trials that we kind of talked about, some of the data that's come out in the Nordic trial, which I believe is in Norway. Basically had the core valve, the Medtronic trial, and basically they had some data out at 2 years. And then also at 6 years, had some sustained outcomes. The only criticism, there weren't a lot of patients left at the 6-year mark. So this is one issue with the trials that are going on, is the low numbers of reaching. But this showed us that it looks good out to 6 years as far as a longer term. In England, there's a registry, again, showing some pretty good durability at 5 and 10 years. But this is at 8 to 10 years is when if a valve is going to wear out, that they start to wear out. So it's still a little premature to call that long term, but so far it's looking good. Here's probably the biggest revolution, the biggest game changer that's come out actually this month in the New England Journal of Medicine. It was published online, I think, back in March. The data, the results are short-term, 1 year and 2 years. This is the Edwards valve, the short valve. The Medtronic valve is that bigger valve. But actually, the Edwards valve was superior to surgery at the 1 year mark in actually all 3 columns. Less death, less stroke, and a big difference in readmission rate. And that's a pretty good driver of cost when we talk about the whole healthcare cost. So, and this is a large study, 1,000 patients. Most of them were fairly young at 73. One criticism of this trial is most of them were male, about, I think, 65% male, so we need to get more women in the trials. But again, TAVR had less irregular heartbeat and stroke afterwards. The one thing that TAVR was in this particular trial, the surgical valves that were put in were bigger than the TAVR valves relatively, meaning the pressure drop across the valve after it got put in was actually better with the surgical valve. So the surgeons responded to those earlier trials by basically, putting in bigger valves. And if there's a choice, say, between one size and the next size, they were kind of encouraged to put the bigger size in. And that's probably what accounted for it. Plus, there were more males in this trial. That may have also driven the fact that the surgical valves looked better. As I was saying earlier, the women have the smaller size, they're more likely to get the smaller valve and have what we call patient-prosthesis mismatch, or essentially a relative grading or relative stenosis left at the end of the day. Better than what they had, but not quite as good as what they were born with. The Medtronic valve actually looked quite good. They had a 2-year follow-up. Non-inferior to death and stroke is actually better. The big negative here for this valve was a 20% pacemaker rate. So 1 in 5 got a pacemaker. One of the main investigators of the trial had a lot of experience, and he put his valves a little bit higher away from the conduction system, had a pacemaker rate down there 5%. So that's something that probably can get better, but that's one of the concerns, particularly in low-risk patients who are going to live a long time. The consequences of a long-term pacemaker, like a lead coming across the tricuspid valve, what will that mean? But one really interesting finding, their valve actually had better gradients in larger valve areas than the surgery valves in this trial. So this is, in my mind, this is quite interesting debate, which of these valves is better, particularly for the small female. There's some different reasons why you may choose one over the other based on anatomy. The other big issue is that's still unresolved is the long-term durability of the valve, and that's kind of where we've come down to with the TAVR valves versus the surgical valves. The surgery valves we have more information about, and we've been doing it longer. We know that the degeneration starts happening at this kind of 8-year mark and really rises at the 10-year mark. Other things we know that the older the patient is at the time of the valve replacement, very unlikely to get a valve replacement, say in their 80s. If somebody's in their 70s, say a 70-year-old female, their life expectancy is roughly 16 years. They get about a 5% lifetime risk of needing a new valve. So we're kind of extrapolating from the surgical data here, but essentially, as time goes on, we'll be able to compare the transcatheter valves to the surgical valves. Here are the pericardial valves. This is one that we commonly put in as well, also made by the Edwards Company. And again, they've had good results. The longest term here, we have 85%, results at 20 years, meaning 85% were functioning well. That's probably of the current valves used, this is some of the best long-term data we have. The good news is the TAVR valve is made out of the same material here, but it is a little bit different, so it does remain to be seen how it plays out. The other advances, and this is not quite as mainstream as TAVR, is aortic valve repair. We're going to have a conference this summer, the Rocky Mountain Valve Symposium. Dr. Lansek and some other docs are kind of re-pioneering aortic valve repair, which has been around for a little while but hasn't had as much long-term durability, putting a ring underneath the aortic valve to look to repair it. So this will be something in the future to see how this plays out. And particularly like the young patient I talked to tonight who was 29, this may be a choice at some point in the future versus giving him a mechanical valve to save his own valve and to avoid anticoagulation. Here's a little bit more of the technique of aortic valve repair, kind of sewn up a couple stitches, and then Dr. Lansek's kind of pioneered a technique where it puts a ring around the base to kind of tighten up, similar to our current mitral valve repair where we can tighten up the valve and essentially get it to come together and not leak. That's pretty much the end of things. So I think in summary, the biggest revolution has been able to replace heart valves without opening the chest or going on the heart-lung machine. I think that's probably the biggest advances, and to many of our surprise, it's become superior even to open heart surgery with really the most important endpoints, which is stroke and death. And so it's pretty amazing to see. The first time I saw it, I was pretty much amazed. There's a game changer. Putting the valve in, and now we did one in 22 minutes the other day, and we're barely even started in open heart surgery at that point. All right, so I see a lot of folks from work here. There's some previous patients, so I'll just kind of open up the floor. We can have questions about these valves or any other heart surgery question you may like.
I'm kind of shocked in watching your presentation when you're talking about the amount of time once you've had open heart surgery. With me, I'm 78 and I was operated on in 71. And is there anything that I need to do to have a checkup on my valves or whatever, or anything that can help me?
First of all, you had coronary bypass surgery, correct?
Yes.
Okay, so you're in a little different category, different type of operations. You had coronary disease, the blood vessels on the surface of the heart. And I'm sure Dr. Maxwell did your surgery, put the mammary artery to the front of the heart. That's the main driver of the survival benefit of your operation. That graph there is the best we have. It's 95% patent at 20 years. So that's really, and then my advice to you or anybody that's had coronary bypass surgery is see a cardiologist every year. If you get symptoms, see them sooner. And if anything changes, you can get a stress test or even go to the cath lab. And once the platform of the bypasses are in place that Dr. Maxwell did, particularly that mammary graft, our cardiologist can stent just about any other situation and get either more durability and long-term survival. It's complementary therapy to your bypass surgery. On occasion, they can't do that, and we have to go and redo the bypass surgery. But really, the survival benefit you've already achieved with the mammary graft that Dr. Maxwell did. Any other questions? Or?
I have a question, Dr. Long. So if after watching this, presentation, which is amazing. Thank you. And I wanted to go get a checkup. I believe the National Heart Institute offers some very affordable.
They do. We have two programs. So one, if you had something going on clinically, obviously your primary care doctor would refer you there if you had some symptoms and get plugged in. We also have a women's heart health clinic that I believe Deb Cybrand's kind of in charge of and can plug in a men's heart health clinic. I think Dr. Jaley's running. So you can kind of get plugged in, get some blood work checked. They can check you out and see if any family history, if you need any further testing. Because that bicuspid valve I showed earlier, if there's any family history of that, I do recommend that all the other family members get checked. Most of the bicuspid valves, patients live their entire life and never need us. But there is an association with the aneurysms or the little more likely to wear out. So just as many things in life, you like to kind of see something coming, and the earlier we see it coming, the better we can deal with it.
Are there any insurance issues or problems with selecting any one of these methods?
We have excellent staff. Get everybody approved.
That's good insurance.
That's probably the best thing, at least you can take off. Right now, currently, Medicare is the main payer for most patients getting the transcatheter valves. CMS is, I guess, the official name of things. The catheter valve right now is only approved for intermediate and high-risk patients currently. As I said, the study just got published this month in the low-risk trials. We're expecting CMS to have a ruling that anyone can get the TAVR valve as a primary choice. Maybe it happens this June, maybe it happens in December. We don't know, or it may not happen, or they may come out and have some qualifications to it. We also have the benefit of a heart team, so some folks calculate out as low risk. So the way we define risk is over 8% predicted rate of death from open heart surgery is high risk. And again, patients had that historically all the time because you're comparing it to a 50% death rate at 2 years, right? So we would still do surgery. But the TAVR became very attractive and that death rate's much lower. Then the intermediate risk we defined as, first one trial was 4 to 8%, the next trial was 3 to 8%. So essentially more than 3% intermediate risk. That's what's currently approved. So some patients, I saw a gentleman today, he was 83, he was 2.6%. When you just run the numbers, but what you have to remember that the database is off a historical database that surgeons have operated on. It produces this thing. So those are actually patients that had surgery. So it's not always that individual patient's risk that's sitting in front of you. So as surgeons and the heart team, we can look at the patient and say, well, actually, you're really intermediate risk. You had a cane, he's a little more frail. So we found that frailty, which isn't in our database predictor for the STS risk, is actually a really big predictor of how patients do after surgery. So many patients qualify for the TAVR valve based on frailty or other medical issues or just a surgeon's opinion that they're intermediate risk, and then Medicare will pay for it. Currently, 2 surgeons and 1 cardiologist have to see the patient, and we kind of talk as a team and then goes on to approval. The private insurance companies basically follow Medicare's lead, right? So right now it's a team approach. My feeling is that with the data being so strong with these early trials, that patients will get a choice of which valve. And then basically the team will look at it and based on their CAT scan pictures, their anatomy, which valve is the best choice for that patient. Or if they need something else done, if they have AFib, I could do a procedure to help treat that, or if they need a bypass. And so it's really become individualized and tailored at this point.
And if a patient isn't under Medicare, what's the cost of this procedure?
The valve itself is about $30,000 for the valve, and the surgical valve is about $5,000 or $6,000. I'm guessing what I believe it's about $50,000 or $60,000 is the cost. So that I think Medicare normally still. We take American Express.
Visa or wine miles.
F-150. We take Sky Miles. All joking aside, we have programs for patients who don't have the money. St. Pat's is excellent about working with people in need.
Will there be less people going into cardiac surgery as far as becoming surgeons because of this, or
It's interesting. I don't know the future. I can tell you what's already happened. Even 10 years ago, less surgeons went into cardiac surgery. Reimbursement for the surgeon went down. Cardiology got very attractive. This was on the horizon. It's a long, demanding training. It's still demanding when you're out. So we actually have a shortage of cardiac surgeons, I think, now. I think it's going to get worse because a lot of surgeons who are still doing are gotten older and they're getting out of it. So I think it's hard to say. I think you will probably have a bit of a shortage, and cardiac surgery will probably re-centralize a little bit, which depends on your opinion, may or may not be a good thing. From my perspective, it wouldn't be all bad to just have, say, Billings and Missoula doing cardiac surgery in Montana rather than Kalispell and Great Falls doing 100 heart operations a year. So I think but flip side, there are a lot of patients that are getting surgery close to home, routine coronary bypass, probably getting treated just fine. So we'll see how it plays out. I think it's all supply and demand a little bit. So, I think it's, if salaries, are good for the surgeon, then young guys will go into it and be willing to do the hard work. So if we have one coming this summer, that's an MSU student, Kevin Thomas. So we got him hooked on it early. Any other questions?
Yeah, I'd like to know what the chances are of me having problems with my aortic valve. I've had some heart attacks, 4 bypasses, a ring around my mitral valve, but so far, after 9 years, no problems with aortic valve. That seems to be.
If your aortic valve has been normal that whole time, and there's stone cold normal, it's pretty low odds you would then go on to develop an aortic valve problem. If they've seen any kind of stenosis that they didn't need to treat at the time, then that is more likely to progress and become something real. So have to look, have to see what your problem. They've said there's been no issues at all. I'm guessing you're maybe 70 or close to it.
Yeah, I'm 76.
Yeah, so mid-70s. If that valve is totally normal now, I think it's pretty low odds. But we do know as people get older that aortic stenosis is fairly prevalent in the population. But you're a little different guess because you've already been imaged, right? So if you look at the total population, that as people get older, 10, 20% get aortic stenosis, whatever it may be. If you're already 76 and don't have it, you almost certainly probably won't get it. It's pretty low odds. But if there's been any kind of changes on the valve already, then it needs to be continued followed. But the good news is if you've had a mitral valve repair and bypass, you're going to get followed with echo. So you'll see it coming.
Yeah, you see me every year.
Okay. All right. Got a little bit of light in the eye. Next time we'll go over the aortic valve images together. Anybody else?
Awesome. Well, thanks everyone. We'll get the movie started. Thank you, Dr. Long.